Right now, I'd like to call up Dr. Samuel Funt from our GU service, who had given the very difficult task of, in 10 minutes, summarizing everything about immune therapy for GU malignancies. And Sam appropriately emailed and said, can I focus on my area of specialty, which is bladder cancer? And I agreed to this. So, Sam, if bladder cancer, I think, is one of those areas where we've really made a lot of progress with immune checkpoint blockade and immunotherapy, although, as we know, bladder has always been one of those kind of immunoresponsive diseases with BCG and such. But Sam, if you will, thank you very much.
Thank you very much, Mike. And I think it's fitting that I follow Matt to talk about bladder cancer because a lot of the same trends you'll see will emerge. We're just a little bit behind in bladder cancer, but have made a lot of progress. My disclosures. So when I started my fellowship at Memorial in 2014, for patients, when patients with metastatic bladder cancer would progress after platinum-based chemotherapy, it was essentially a uniformly fatal diagnosis. We had very limited treatment options in the form of single-agent chemotherapy, taxane, pemetrexed. These are the data for vinflunine in Europe, with an overall survival of about 7 months, a PFS of 3 months, an overall response rate of about 10%. So the options were not good back in 2014. As Michael said, actually, we have a lot of rationale for using immunotherapy in bladder cancer. We've been using BCG to cause an immune response in the bladder for non-muscle invasive disease since the 1970s. We have a high mutation burden, so there was a lot of excitement going into investigating immunotherapy for this disease, for bladder cancer. And so what is the evidence supporting the use of immune checkpoint inhibition for platinum refractory metastatic bladder cancer? And these were really the first data, for the first phase 2 data that were released in 2016. We had phase 1 data in 2014. This is the IMvigor210 trial, cohort 2. There were 310 patients enrolled in this trial, and what was really striking, as was seen in other diseases, was the durability of response. 71% of responses ongoing at the time of the data cutoff. We treated about 30 patients here at Memorial on this trial in 2014. We enrolled 30 patients. We're 5 years later, we still have 6 patients that are still responding, which was basically unheard of with platinum refractory metastatic bladder cancer. You'll see from this trial that, again, the biomarker PD-L1 seemed to enrich for response. You could see that the overall response rate in the PD-L1 high group was 28% versus the PD-L1 low or negative group close to 10%. So Genentech used this rationale to design a phase 3 trial, the IMvigor211 trial. The primary endpoint for this trial, which was randomizing patients with platinum refractory bladder cancer to either atezolizumab or single-agent chemotherapy, was overall survival in the PD-L1 high population. And it turns out that actually this trial was negative for an overall survival benefit. And the reason that we think that we saw this result was actually the PD-L1 assay that they used, the Ventana SP 142 assay, seemed to be a positive prognostic biomarker, that actually the patients on chemotherapy did much better than expected. So while the trial did not meet the overall survival endpoint for atezolizumab, the drug remained on the market based on the previous IMvigor210 data, with another confirmatory drug being done. Now, what did stick out was that the patients that responded to immunotherapy had a much longer duration of response. This is the Keynote 045 study. So these are the data with pembrolizumab in the same patient population, platinum refractory metastatic bladder cancer. These took all comers. The overall survival in all comers was the primary endpoint for this study, irrespective of PD-L1. Patients were randomized to pembrolizumab or single-agent chemo, and there was an overall survival benefit for patients in this study. With a hazard ratio of 0.73. Now, just going back to the PD-L1 biomarker question, this is a different assay. This is the 22C3 assay. You could see that patients, pembrolizumab actually outperformed chemotherapy in the PD-L1 high patient population, but patients overall did worse. The PD-L1 high patients did worse than the overall patient population. Pembrolizumab with an overall survival of 10.3 and chemo with 7.4 months in the overall population, whereas in the PD-L1 high patient population, 8 months and 5 months. So what do all these data mean? Atezolizumab, we know, is an active drug in patients with platinum refractory metastatic bladder cancer. It still remains on the market. It seems that their PD-L1 assay was more of a positive prognostic biomarker predicted for better responses with chemotherapy and immunotherapy. Pembrolizumab is the only drug in the disease with level 1 evidence. There was a positive randomized phase 3 trial that I just showed you, and it seems that their PD-L1 assay is associated with more of a poor prognosis and is not useful for patient selection. There are actually 3 other PD-1, PD-L1 blocking antibodies approved in bladder cancer, more than any other disease. And these are the data for those antibodies in patients with platinum refractory disease. So there's a patient population with metastatic bladder cancer that is too sick, essentially, due to medical comorbidities, to get cisplatin-based chemotherapy frontline. And this constitutes about 50% of the overall population of patients with bladder cancer. It's an elderly population with a lot of medical comorbidities. So we use typically carboplatin-based chemotherapy in this patient population, and the overall survival for those patients is 9.2 months with frontline therapy, so sort of a low bar, an unmet need. And so there were 2 trials that have been reported specifically in this patient population using atezolizumab and pembrolizumab, 2 separate trials in this patient population using it as frontline therapy. And the median overall survival that was reported from the atezolizumab study, cohort 1 of the IMvigor210 study, was 15.9 months. Again, a lot better than the 9.2 months that we had seen before. Similar data with pembrolizumab. Both of these drugs have accelerated approval in this patient population. And these data were used as the rationale for 2 separate phase 3 studies that sort of have very similar, or do have very, very similar designs. Chemotherapy plus PD-1 alone, and chemotherapy plus placebo, 2 sort of very identical trials. Now, in May of last year, the DSMCs for both of these trials simultaneously halted the trials because it seemed that patients that were PD-L1 low that were randomized to either pembrolizumab or atezolizumab monotherapy had decreased survival compared to both of these chemotherapy arms. And so they halted these studies. They halted accrual to the PD-1, PD-L1 monotherapy arms. And actually the FDA changed the label for the drugs. So this kind of body of data essentially sets the stage for the standard of care right now for patients with metastatic bladder cancer. If you're previously untreated and you have metastatic bladder cancer and you're cisplatin eligible, the standard of care is still to get cisplatin-based chemotherapy. If you have metastatic disease and you're cisplatin ineligible, you can get atezolizumab or pembrolizumab, but you need to be PD-L1 high. If you're PD-L1 low, it's chemotherapy. If you have metastatic disease and you've had prior chemotherapy, the only immune checkpoint blocking antibody, although there are 5 approved, is pembrolizumab. And if you have metastatic disease and you've progressed after prior chemotherapy and immunotherapy, this is the patient population with the greatest unmet need. I should say in April of this year, we actually had erdafitinib approved for patients with FGFR3 alterations. So in terms of the next big question, what are the data for combination strategies in patients with metastatic bladder cancer? So actually, I showed you the DSMC recommendation, but we just have from ESMO 2 weeks ago some data from the IMvigor130 study, again, randomizing patients chemo-atezo alone, and chemo-placebo. And these are the PFS data that are mature. It was co-primary endpoints, PFS and OS in this trial. And the trial did meet the PFS endpoint. The hazard ratio is 0.82, an improvement in PFS of about 2 months. This improvement seems to happen later where the curves separate. Still, I think, remains to be seen whether or not this will set the new standard of care in patients with previously untreated metastatic bladder cancer. They treated patients with both carboplatin-based regimens, which actually was the majority of the trial, and cisplatin-based regimens. The overall survival data is not yet mature, This is, though, the first trial really to show a PFS benefit in patients with previously untreated metastatic bladder cancer. So a big question is how this data will be incorporated moving forward, and we're anxiously awaiting further results. In terms of other combination strategies, CTLA-4 and PD-1 blockade have been used, obviously, in other diseases, as I'm sure we'll hear about. There was very recently published data with the combination in patients with metastatic bladder cancer previously treated platinum refractory. It did seem that, and this was looking at either Nivo monotherapy, Nivo 3 IPI-1, and Nivo 1 IPI-3. It did seem in the overall patient population, the overall response proportion was better with Nivo 1 IPI-3. This difference actually went away in the PD-L1 low patient population, but when you looked at the PD-L1 high patient population, the difference was striking. Actually, the Nivo 1 IPI-3 dose had an overall response rate nearing 60%, which was striking. And so this set the stage for other randomized trials. The Checkmate 901 study, which is comparing patients with previously untreated metastatic bladder cancer to Ipi-Nivo at the Nivo 1 Ipi-3 dose and chemotherapy, and also a similar trial being done with the AstraZeneca PD-L1 and CTLA-4 inhibitors. I'll just end with a very new, exciting drug in the care of patients with metastatic bladder cancer, which is enfortumab vedotin, which is an antibody-drug conjugate targeting Nectin-4. These data were also very recently published, phase 2 data in patients with chemotherapy and PD-1 resistant disease, showing an overall response rate of 44%. A duration of response of 7.6%. So a very active drug, certainly in reducing disease burden. Durability does not initially seem to be as long as with immunotherapy, which again set the stage for this combination strategy that we just saw 2 weeks ago at ESMO. The combination of enfortumab vedotin and pembrolizumab as first-line therapy, again in this cisplatin-ineligible population. And initially, as you could see from this waterfall plot, the data look very good thus far, and current trials are ongoing. So in terms of remaining questions, obviously a big one is how do we move beyond PD-L1 as a biomarker? Each drug has its own PD-L1 assay. They seem potentially to mean different things. How do we move beyond that in terms of other biomarkers? And obviously there's a lot of work being done incorporating immune checkpoint blockade in patients with earlier stage disease. The majority of patients with bladder cancer actually have muscle invasive disease, and so immune checkpoint blockade is being evaluated in that population and in patients with muscle invasive disease as well. Thank you very much.
I think we have time for a question or two for Sam. So, yes, Omar, real quick.
You know, on that couple of slides ago, the Nivo 3 IPI-1, that on that middle slide, you're using a less than 1% cut point. If you used I mean, I would think that the IPI-3 would have filled the gap, but it didn't. I mean, in melanoma, apparently it fills the gap pretty nicely, and you get that green, which one is it? The green one should have been up high. Any thoughts on why the IPI didn't pay off here?
No, I think that there's a lot of biology to be worked out here. I don't think we know. Part of the problem is that all the PD-L1 assays use different cut points. Oftentimes, even the cut points we use for the same drug, the same assay, different diseases will be different. So this is what they happen to use in Checkmate 032. I don't know the answer to that question. You know.
Then I just have a quick question for you, Sam. So bladder cancer, at least muscle invasive, non-metastatic disease, one of the big paradigms that's come out is neoadjuvant chemo in historical basis. What's going on now with immune therapy? Because this has been a really great platform where we could learn a lot about pre-post tissue biopsy and resection of the bladder in neoadjuvant context. So where are we with neoadjuvant immunotherapy for locally advanced bladder?
Yeah, that's a great question. So for patients with muscle invasive bladder cancer, the standard of care, if you can give it a cisplatin-based chemo, then removing the bladder. There were recently some data from the group in Italy, the Puro-1 study, looking at pembrolizumab actually in that setting, in perioperative setting, and the pathologic downstaging rate in that study was striking and was very encouraging in terms of in comparison with what we see with GEM-CIS. The long-term, there's a lot of questions about that study. It's not yet standard of care. In patients with muscle-invasive bladder cancer. I think we need to see that data replicated. We need to see longer-term outcomes, ideally a randomized clinical trial. You're correct that we are able to get that post-treatment tissue evaluate because it's standard of care. You remove the bladder, you remove the bulk of the tumor. We're able to study for mechanisms of resistance, certainly. At Memorial, we're looking at the combination of GEM-CIS and atezolizumab in the neoadjuvant setting for patients with muscle-invasive bladder cancer. We're also looking at Ipi-Nivo and Ipi-Nivo in patients who are cis-ineligible with muscle-invasive bladder cancer. So I think it's a great paradigm, for for unraveling biological mechanisms, but I think it remains to be seen, the standard, what the standard of care will become.
Okay, great. Thank you, Sam. Really appreciate it.